Should I mute mine also?
Yeah, you can mute for now.
Okay.
Yeah, so at least they're getting many attendees. We are at 156.
Yeah.
So we give guys a few more minutes to settle in. We'll also be streaming live from Facebook, so that's something I'm trying to set up. So good evening, everyone. We are trying to settle down as we wait for more people to log in. Thank you very much for joining us on our webinar tonight, this evening. So we will be beginning shortly. So you're all welcome. Karibu sana, that's Swahili for welcome. So hopefully we will begin in the next few minutes as we wait for everyone to log in, as we wait for the speaker as well. So we remind you again, thank you for joining the webinar organized by the Kenya Association of Pediatric Dentists. We invite every one of you to join, even our counterparts from Zimbabwe. We are always open for members from regional countries. The association is open for specialist pediatric dentists, for general dentists who are interested in pediatric dentistry, for undergraduate students and postgraduate students. So we welcome you to join our association, as well as the Zimbabwe Dental Association. But Dr. Soka, I'll give you a minute later to talk about ZIDA. So we are currently waiting for the speaker who's with us. So we give him a few more minutes.
Thank you, Nick, for having us.
You're most welcome.
Yeah, we are excited about this collaboration. We are looking forward, to work on this regional integration initiative. I think for me, this marks a good start, for us to start sharing ideas, sharing skills, and also sharing knowledge. And I think there's a lot that we can share, professionally. A couple of our members are already coming to Nairobi for training, so there's already some relationship going on, between Harare and Nairobi, and I think we would love to build on it, and but for me, more excitingly, that we develop our own people, we develop our own speakers, we develop our own board of local knowledge, indigenous knowledge, to our in our specific environment, So I am very excited, and I'm sure it is with our members from the Zimbabwe Association. We are all happy to be part of this joint webinar. So, and also thank you to Dr. Simiyu, an exciting topic we are all, I mean, quite eager to learn and listen to your experience as well. Nick.
Yeah, so I think now we can begin. We are at 238 attendees. So welcome everyone, good evening. It is my pleasure to host again and moderate today's webinar, which will be filling root canals with nerves and blood vessels, featuring regenerative endodontics. Today marks our first collaborative webinar. We have co-hosted this webinar together with the Zimbabwe Dental Association. We've been joined by Dr. Tsoka, who is the association's president, and Dr. Vicky Constance, a member of the association and a friend of our association. She's been to Nairobi several times. We've been joined by Dr. Simiyu, who is our lecturer for today. He's an endodontist practicing in Kenya, having specialized at the University of East Philippines. And he's also the founder of the Endodontics Academy. And hopefully we will be taking part in some of his training very soon, because we are very, very eager to learn the new skills in endodontics. So we welcome you. Dr. Tsoka, I don't know whether you'd like to say something about ZIDA for yourself and for your members, and maybe Dr. Constance can also say a big hi before we begin.
Is it? I think I'll just hand over to Dr. Vicky maybe to say a few remarks, but just to say that we're excited to be here, and we are, like I said, want to invest more in these collaborative initiatives to really develop our own, you know. So this is what I'm really looking forward to from a ZIDA perspective. I don't know, Constance.
Okay, evening everyone. I would like to start by saying thank you to the Kenya Association of Pediatric Dentistry for this opportunity to share with us. A welcome to your members in Kenya and to the Zimbabwe Dental Association. We look forward to more collaborations which are similar to this. Thank you.
Yes, we hope to foster more collaborations regionally as well. So we welcome everyone, especially those from Harare. Karibu sana. So over to you, Dr. Simiyu, to your much awaited lecture.
Thank you very much, Dr. Gishu and the team, the Kenya Dental Association, and ZIDA, Zimbabwe Dental Association, the Kenya Association of Pediatric Dentists, which I'm going to be a member very soon, because actually we are closely related in endo and in regenerative endodontics specifically. So much has been introduced about myself, so let's just go directly to the topic today. And we're going to look at filling root canals with nerves and blood vessels. This is basically regenerative endodontics. To start with, in introduction, we can say that clinicians face several challenges when presenting with an incompletely formed root in need of endodontic treatment. Because the apex is not fully closed, like you can see in this picture, the apex is really open. So there are so many mishaps that can happen when you're handling such a tooth. The process is further complicated because the walls are thin and fragile. The walls are thin and also fragile. So in addition, the open apex increases the risk of extruding materials into the periapical tissues. As a way of introduction again, traditionally, we've been using apexification, which involves creating an apical barrier to prevent extrusion. In many cases, this entails an involved long-term treatment with calcium hydroxide, resulting in the formation of hard tissue apical barriers. The numbers ahead of the slide just shows the reference that I was making. I was supposed to remove them, but they are just citations for the references. A disadvantage of apicification is that we are holding this tooth at a state of arrest. And long-term and short-term use of calcium hydroxide have been known to cause reduced root strength. Actually, it weakens the root in as much as forming, allowing the tooth to form an apical barrier. At the same time, studies have shown that eventually these teeth usually break. Research shows that a major reason for tooth loss following apicification was root fracture, as I said. So what's the definition of regenerative endodontics? These are biologically based principles designed to replace damaged tissue such as dentin. As you can see in this picture, the tooth is made of the dentin. That's basic knowledge for all of us. And the pulp, the root, and the crown. So the aim of filling the root canal with nerves is to fill the pulp that has undergone necrosis. So this will allow continued root development, immune competence, and normal nociception. Immature teeth treated with such procedures like apicification are considered to be in a state of arrested development. So we have to do regenerative endodontic procedures in order to restore these functions of nociception, immune response, and development. Various methods and materials have been suggested to deal with teeth having immature apices. The aim is actually to increase the thickness of the dentin and also to initiate complete root formation. The aim of regenerative endodontic procedures is to replace the irreversibly damaged pulp with a newly regenerated tissue in attempt to complete root maturation. In this presentation, therefore, what I'm going to do is clinical consideration of regenerative procedures, emphasizing on the outcome. Are they viable? Is it something to consider? And then I'll also update you on 2 cases that were done, among many of them that have been successful. In this case, the Prof. Zivek, actually, we know him as Zivek Palpotomies. I think pediatric dentists must know Prof. Zivek. He's the one who came up with this classification. In A, you can see a very teeth in different stages of development. In A, it's just a very young tooth. Even the root has not yet formed. It's in the stage of development. B, you can see is growing, elongating. C and D also. Between A, B, C, as you can see in this slide, these are the candidates for regenerative endodontic procedures. In D and E, you may actually do apicification because the root is almost closed. However, you can attempt also regenerative endodontic procedures. These procedures are done in young permanent teeth where you have no option of doing the normal endodontic treatment procedures. So Professor Zivek classified them A, B, C, D at different stages. Stage 1 corresponding to A, stage 2 corresponding to B, stage C corresponding to 3, and then D and 4, E for 5. So we have to know the difference between regeneration and repair. Why are we going to do regeneration? In regeneration, we are going to restore the original function and structure. We are going to restore the damaged pulp and the damaged neurovascular bundles inside the tooth. How about repair? In repair, on the other side, there is loss of function and structure. Repair is not ideal wound healing, but it's acceptable. Even though you do repair, for example, apexification, apexogenesis, it is really not an ideal wound healing, but it's considered a clinical treatment. It's not a treatment failure because you are going to retain this tooth in the mouth without any symptoms, without any disease, and therefore you'll be able to restore the function of the patient. So the dental pulp is an organ. On the top diagram, you can see different organs. The heart, you can see the liver, the pancreas, you can see what? The kidneys. All these are organs. The pulp is also an organ, meaning it has different cells with different functions. If an organ loses its ability to do function, the only thing we can do is transplant. So you've had people go for transplant, kidney transplant, heart transplant, liver transplant. Why? They are organs. The moment they are destroyed, they can no longer able to produce or do the function. The only remedy is to do a transplant. In that perspective, also take the dental pulp as an organ. The moment caries goes in and then causes necrosis, it's really hard to restore. However, thank God, because of tissue engineering, regeneration, so we are able to revive these cells that were once dead, so that to restore function and sensation of the pulp. Because this dental pulp has several different cell types, as I said, to perform different functions, therefore it's considered as what? An organ, just like the liver, just like the kidneys, just like your heart. So the only remedy, if it's destroyed by what? Caries, trauma, is to do what? An organ transplantation. So are we ready to do organ transplantation in teeth? Let's see in the next series of slides. Our hope is tissue engineering. The most successful engineering we have seen in organs is in the eye, the cornea of your eye. Recently in medicine, they're able to do engineering of the cornea to restore vision to people. People who have lost vision because of corneal problems, they're able to see right now because of tissue engineering. This technology in medicine is now being applied in dental medicine too, to restore the tooth and its function. So it's all about tissue engineering. And let's do an overview of it, okay? So this one is an interdisciplinary modality, applies principles of engineering to restore, maintaining, and all the biologic functions. When we talk about tissue engineering, there are three principles we want to talk about. The stem cells, I will talk about stem cells. Before we form blood vessels, before we form cells, nerves, odontoblasts, cementoblasts, all those immune cells in the pulp chamber, we must have stem cells. We must have what? Scaffolds. I'll share more about scaffolds and other signaling molecules, for example, the growth factors. So it's interplay between those three factors. And an overview of, just a minute. A recent study in regenerative endodontics revealed that this is a paradigm shift in endodontics, actually. We are now shifting from the normal apification, apexogenesis in young permanent teeth to actually do regeneration of these teeth. So this is a paradigm shift. So we are going to look at the three principles of tissue engineering. Number one, stem cells. For us to form the pulp, which has been damaged, this is an organ. We cannot do transplant of the pulp, but we can use stem cells. Three things: stem cells. Number two, growth factors or morphogenes. and then scaffolds. I'm going to talk about these three, and then we are done with the lecture. And then I'm going to show you 2 cases that were done using this procedure, and they're really successful. The tooth that was necrotic with apical periodontitis with radiolucency were able to respond to pulp vitality tests. So let's talk about stem cells. Stem cells are distinct population of undifferentiated cells. They could be pluripotent or multipotent. Pluripotent ones are embryonic cells. When we talk about stem cells, the original cells that formed us, we had pluripotent cells. These are embryonic cells. They include what? The mesoderm, ectoderm, and endoderm during embryonic stage of development. To have these cells, you must have to kill the embryo. Therefore, you are destroying life. Because of ethical issues, we do not use pluripotent stem cells in medicine or in dentistry. Otherwise, you'll have to kill all embryos for you to harvest the stem cells. However, from pluripotent stem cells, we have multipotent stem cells. These are adult mesenchymal cells, which have migrated already in the eye, in the nose, in the brain. They have gone to the tooth pulp chamber in the periapical region of the tooth, and they're able to reproduce cells of mesenchymal origin, like the tooth. So regenerative endodontics is going to use the multipotent stem cells because they are specifically designed to produce tissues or cells responsible for a specific function. Which are these stem cells? In this picture, they are housed in a niche. So this is like a stem cell bank for dentistry. You can have them from the bone, so they're called bone marrow stem cells. If they're around the periosteal, they're called periosteal stem cells. If they're around the PDL, they're called the PDL stem cells. If they are found in the apical region, in an inflamed pulp, like you can see, it's called IPAC. So IPAC is inflamed periapical stem cells. And then in exfoliated teeth in children, they are called SHED, S for stem cells of human exfoliated dentition. You can harvest them actually from the tooth, young permanent teeth. And now this actually, some people are, after extraction of their young permanent teeth, they're harvesting these stem cells and store them in a stem cell bank. When your children are shedding their teeth in developed countries, people are harvesting this deciduous teeth, the stem cells, the growth factors, and they put them in a bank somewhere so that should other teeth have problems, they are able to use these stem cells and then regenerate the damaged tissues. So these are just the niche, or where are these stem cells found? And remember, these are the multipotent stem cells, adult mesenchymal stem cells, which have already taken a center stage, a position or a niche somewhere. When you dissect a young permanent tooth, you will harvest a pulp. You can see in this diagram. Now this pulp, on your left, it is a whole pulp. Inside is a loose connective tissue with blood vessels, nerves, and all other cells, immune cells, stem cells, even the cytokines and all other inflammatory mediators. The aim of regenerative endodontics is to lacerate, intentionally lacerate this tissue to induce bleeding. Stem cells are provoked by actually an immune response. If there is caries, there is trauma, then there is a sequence of signaling transduction that's happening all the way from the stem cells until we get a fully formed tissue. In this picture, you can see the the red markings, this is like the blood, loose connective tissue. So in regenerative endodontics, we intentionally lacerate or traumatize, if I can say it, but the proper term is laceration. It's like you're cutting. So lacerate this apical tissue so that there's blood, and then the stem cells are released, they differentiate, and then they form odontoblast-like cells, which are going to form dentin. Others will differentiate to form nerve cells, so which are going to produce nerves. Others will differentiate from the bone marrow to form what? The blood vessels. Therefore, we are going to have blood circulation in our newly formed tissue. So let's look at number 2. We say there's a triad in regenerative endodontics. Number 1, we have finished with stem cells. Number 2, we need growth factors. So the stem cells that have been released need growth factors for them to grow. And dentin, by the way, the dentin, whenever we cut cavities, the dentin is always a reservoir of growth factors and cytokines. And they are secreted by odontoblasts during primary dentin formation, and they are fossilized. So the dentin is not just a plain tissue as you cut it. It has fossilized stem cells, and they can be extracted using some chemicals, for example, EDTA, as you will see, and etching. When we etch, we are dissolving organic matter, inorganic matter, and therefore we like harvest this reservoir of cells. So we've looked at stem cells. Now we are looking at growth factors, the triad of regenerative endodontics. This could be growth hormones, insulin growth factors, tumor transforming growth factor, beta, and even bone morphogenic proteins. Now let's talk about EDTA. EDTA is a solution that is used to expose these fossilized stem cells, and it should be 17% EDTA. That's why in endodontics, during smear layer removal, after your biomechanical preparation, we always use 17% EDTA solution. Now in regenerative endodontics, the 17% EDTA solution is used to expose the hidden, the fossilized stem cells, the growth factors. They come out when you rinse your canal with EDTA solution. Let's see. So it increases survival of these stem cells and exfoliates the bioactive molecules from dentin. Now, another thing that can help us harvest these growth factors is what? Phosphoric acid, the agent. The agent we always use is used for conditioning the dentin. It also promotes demineralization. When we are etching, we are demineralizing this dentin, therefore releasing some growth factors. Calcium hydroxide also remains in place beneath the tooth. What happens is that allows continuous dissolution, therefore releasing growth factors. Yeah. So the triad again, number 1, stem cells. How can they be released into the site? Trauma, inflammation, or regenerative endodontics. Number 2, growth factors. How can we get them into the pulp? You use biomaterials, 17% EDTA, etching, and then dical, calcium hydroxide of any brand is going to help to exfoliate these hidden growth factors. And the last one in tissue engineering is scaffold. This is where the research is now in endodontics. The first 2 factors, the stem cells, we have them in our bodies, okay? And then the growth factors, number 2, we have them. The scaffolds, this is where engineers, biomedical engineers, in medicine are trying to come up. This is like a 3D replica of human tissue. In your screen, you can see a mesh wire of an architect if you can see on the bottom right of your screen, there is a house or being constructed, a tower that's being constructed. What are the engineers doing on top there? They're laying out a three-dimensional foundation of this structure so that the cement, the timber, whatever fittings they are going to do on this structure, it will come just the way they have outlined it with this wire mesh. So this is a 3D replica. In endodontics, specifically regenerative endodontics, and in medical engineering, we also use the same. We use mesh or something so that we can be able to produce a 3D print. These are called scaffolds. So scaffold simply is a 3D blueprint of the engineered tissue. The tissues in our bodies are organized in a three-dimensional foundation. Therefore, scaffolding is necessary to provide a spatial correct position of cell location. So we know which cell goes to which corner, and then regulate differentiation so that cells do not overreact to form a tumor, or they do not undergo apoptosis. So they're able to proliferate and then metabolize so that we can have the desired tissues. Now, scaffolds, on your screen you can see, previously, in the previous slide, you can see an engineer laying out metallic poles to form what? A 3D. In the next slide, in this picture, you can see a 3D of a human body. Actually, this one is like a blood clot formed by fibrin and fibril strands interconnected with cells. You can see star-shaped cells and all those. So this one is our biological engineering scaffold that's created. On top of this wire mesh, that is where we are going to plant the growth factors. They need to be sustained until the building is full. Just look at the engineer's building we saw, just wires, and then he will fill in the details with cement. He will fill in the details with doors, windows, everything. Now in regenerative endodontics, we need a scaffold like what you can see on your screen. It's like a mesh, 3D mesh, where the first two factors, the stem cells will lodge there, and then the growth factors will lodge there so that we can form the nerves inside the pulp. Examples of natural scaffolds. So which are these scaffolds? Others are manufactured, others are just natural. For example, collagen. So collagen is our natural scaffold. Another one is aminoglycans. These are natural scaffolds. Hyaluronic acid is a natural scaffold. And then dentin matrix is our dental scaffold. And then fibrin from blood. Like you can see the picture on your screen. Actually, this looks like a blood clot with the fibrin strands and cells on top of it. So this one is our natural scaffolds. How about synthetic? People have also tried to manufacture synthetic ones. A simple example is polylactalic acid, the Vicryl. The Vicryl, the suture we use, this one is an example of a synthetic scaffold. Others could be, so the trade names, for example, polyglycolic acid, polylactic acid, the trade names could be like Vicryl, the suture that we use. This one is an example of what? A synthetic scaffold. So you can see in this diagram, we have polymers, mesh. This one looks exactly, now we are talking about tissue engineering, exactly like the architectural building you saw with poles, metallic poles interlaced to one another. Therefore, in dentistry and medicine, we also use this kind of scaffolds. You can discover one and then you can use it where the cells will lodge and then differentiate and then multiply, giving you the tissue that you want. An example is a blood clot. So This is an example of a blood clot. You can see the cells, yeah, the red blood cells. You can see the vibrils, very beautiful, engineered and designed by God himself. This is the best scaffold you can ever have in regenerative endodontics. The ones we manufacture by our own human standards could not match this, but this one is the best that we are going to use, especially in the next series of cases that I'm going to show you, only 2 cases. So a blood clot can serve as what? A scaffold. Or you can harvest blood and then you can have what? Platelet-rich plasma. Of course, phlebotomists and hemo, the people specialized in blood will draw for you, do centrifugation until you get what? They undergo all those processes so that you get what? The autologous platelet-rich plasma. Another one is platelet-rich fibrin. So you have to have a phlebotomist and then a specialist in blood who are going to harvest blood, and then they are going to make for you what? Platelet-rich plasma or autologous platelet-rich fibrin. Example, now, when you have someone to draw blood from your patient, of course, you need to have a delivery system. So what's happening is that we have existing cells, for example, in the bone marrow, as you can see in this picture A. So we have cells existing in the bone marrow. They are released by chemotactic factors and other signaling molecules. And then they enter the blood vessels. The cells, they enter the blood and they migrate. This is called cell trafficking with the aid of blood flow. So the cells are released from the stem cells. They migrate along the blood vessels, and then they go to the area of target. This process where cells are recruited from one side to the other side is called homing. I want to introduce you to a term in regenerative endodontics called what? Homing. So cell homing, simply in a layman language, is cells released from one side, and then they are going to migrate to another side where they are going to form, differentiate, proliferate, and form a new tissue. So biomedical engineering using a cell homing approach, as I told you, in cell homing, what we do is what? A cell migrates from one place to the other. In this picture, you can see an immature premolar with a necrotic pulp and apical lesion. If you can see on your screen, there's a huge periapical lesion by color black. So you can see the black color, and the blood vessels are trying to bring in oxygen, nutrients, but the pulp cannot accommodate them because there's a lot of bacteria inside. So in your practice, you might experience such a case. Young permanent tooth with periapical lesion, the pulp is necrotic. You want to bring it back to life. So what do you do? In this case, you do disinfection. So we are talking about the protocol, the procedure, step-by-step procedure of regenerative endodontics. Number 1, you take the history of the patient. You take a preoperative radiograph, and then it must be a young permanent tooth. And then whether with apical radiolucency or no apical radiolucency, in figure B, you are able to disinfect. The recommended disinfection protocol is minimal. Actually, we don't use rotary files. They recommend minimal because if you use aggressive files on the wall, you are going to thin the walls. Also, you are going to remove the potential reservoir of stem cells along the wall of the dentine. So you do minimal disinfection. I'll show you in details. And then after that, you place a biodegradable scaffold containing growth factors. So S is for scaffold, and then G is the growth factors to allow progressive proliferation and migration of apical stem cells into the canal space. How are we going to do that? We use biomaterials. I'm going to show you in the next case. You use biomaterials which are going to attract these cells into the pulp chamber. At this moment, you have done disinfection. So the pulp chamber is hollow. Is hollow, nothing inside. So you have to attract cells. So you put a biomaterial that's going to cause homing of these cells to get out of the periapical area, which you can see from the blood vessels that are still vital, and then they migrate up into the tooth. So population of canal space with stem cells will come in, and then they will cause vascular supply and tissue organization, as you can see in the last picture. So eventually these cells from the periapical region, they are going to migrate upwards into the pulp chamber, because you have asked, why should they go up? Why should they go up? So they are chemotactic agents in growth factors. And then the scaffold also should aid in chemo attraction. So these cells can migrate and then form substantial tissue inside the pulp chamber. At this moment, the periapical region, as you can see in figure D, the right picture on your screen, there is no more periapical lesion. Therefore, the pulp chamber has itself organized itself. Now, which medicaments do you use? There's a lot of research, by the way, undergoing in this panel, in this area. Initially, in Japan, there is a scientist, I think it's called Hoshina. He came up with a triple antibiotic paste. It consisted of what? Metronidazole, ciprofloxacin, minocycline. You have to put an intracanal medicament inside the necrotic pulp tissue. So the first person to try this was to use a triple antibiotic paste consisting of metronidazole, ciprofloxacin, and minocycline. However, with time, minocycline, which is a class of tetracycline, caused staining. Therefore, minocycline was dropped. So we no longer use minocycline. And then they replaced minocycline with cefaclor. So cefaclor caused less staining. As you can see, it has replaced now minocycline. So there's no more, there's reduced or mild staining after your regenerative endodontic procedures. Someone said, why can't we just do with two? We don't need minocycline, which will cause staining. We don't need cefaclor. So they came up, they strike out the third biomedicine. So they came up with what? A double antibiotic paste. So research is evolving. So we came from triple to double, and where are we currently? Guess what? There is no more triple. There is no more double. There is a single one antibiotic paste. This was in 2017. And now research is here. Why? Augmentin, as you see, it kills bacteria by inhibiting cell wall synthesis. Of human cells, as humans, you and me do not have cell walls. Our body cells do not have a cell wall. Augmentin acts by inhibiting the cell wall synthesis in bacteria and other microbes. So it's the current safest antibiotic you can put inside the pulp chamber. Actually, 100% of microorganisms are instantly killed by augmentin. So at this moment in time, we are on one antibiotic paste, not three, not two. And others are trying to mix the two. But of course, augmentin is now taking center stage. Unlike other antibiotics, so other antibiotics, they target bacterial proteins and DNA synthesis. Augmentin inhibits bacterial cell wall synthesis. As humans, our cells do not have a cell wall. So we are safe with augmentin. So human cells do not have a cell wall. Therefore, augmentin only affects bacterial cell walls. And this is safe. Why? The stem cells coming on site to build this tissue, they are not damaged by the augmentin because they don't have a cell wall. So augmentin currently is the epitome of research now. So clinical procedures are related to regenerative endodontics. Another medicament, intracanal medicament, which we've been using, so people said, why are we using antibiotics? Because there's allergic reactions. Of course, some of them will cause body hypersensitivity and now antibiotic resistance. So if you use constantly minocycline, metronidazole, ciprofloxacin, even augmentin, with time, you might develop what? You are going to develop resistance to antibiotics. So people also came up with alternatives such as calcium hydroxide. You can put this calcium hydroxide to disinfect as an intracanal medicament to disinfect because of its high pH. Therefore, it has a very good power to kill all the microbes. So it should be used in a short time, actually not more than 2 weeks. So if you're dressing your canals with calcium hydroxide, please recall your patients between 2 to 3 weeks. More than 1 month, calcium hydroxide has been shown to cause weakening of the pulp, of the tissues and of the wall. Therefore, the root will become even more weaker. Okay. Another thing, so what do you choose? Is it calcium hydroxide? Is it triple antibiotic paste? Is it a double antibiotic paste or the single antibiotic paste? Or no antibiotics, but calcium hydroxide? How do you choose? It depends. How easy are you going to remove these medicaments from the canal? Now, research has shown that it's easier to remove calcium hydroxide than antibiotics, whether augmentin, whether the triple or the double antibiotic paste. They're hard to remove on the second visit. You put them as intracanal medicaments, but it's hard for them to come out. And we need them out so that we fill the pulp chamber with stem cells. Therefore, currently people are doing more research on calcium hydroxide because it's easy to remove. You just use 17% EDTA solution, and then you're going to remove this calcium hydroxide. Let's go back to Prof. Sivek, the first picture we saw. So what are the factors do you consider? As I said, 1, 2, 3, age of the patient, at least 8 years, 8 to 18 years without open apex, you can do regenerative endodontics. So you must consider the patient age and the stage of development of the tooth. Because regenerative endodontics has a lesser outcome in adults. Why? Our stem cells, as we grow older, they have a reduced potential to form new cells. So they have reduced potential to form new cells. So age is an important factor. And the stage of root development. On your screen, you can see 5 pictures. Stages at different stages of development. Stage 1, 2, 3, A, B, C, you can do regenerative endodontics, even D and E. However, with D and E, because the root is almost closing, you might do just an apical plug with MTA. In D and E, you can do an apical plug with MTA. But A, B, C are the best candidates for regenerative endodontics. Now let's look at 2 case reports in the next 3 slides, 4 slides, and we are done with this lecture in regeneration. So what's the procedure? You have a case with open apex. You want to regenerate the pulp, the nerves. What's the procedure? Number 1, you can see in A is what? Clinical examination. History is important. Or you've come to me, what's the history? Is it trauma? How many hours? Is it 24 hours? Is it a year? Is it months? History is important. And then you examine the patient if they have any discharging fistula. And then you do percussion tests, just like medicine: inspection, palpation, percussion, no auscultation. So the 4 quadrants in medicine: inspection, palpation, percussion, but no auscultation of the tooth. So, and then you take a radiograph. In the radiograph, you'll see in A, there is a tooth. It's a 2-1. It's the first, it's a central incisor, which has got an open apex. So this is your case. What do you do next? You do access cavity preparation. So we are doing regenerative endodontics in this slide. So what's the protocol? Number 1, history, examination, and pre-op radiograph, important. Before even you start doing access cavity, you have to ask patient the consent, both the patient and the parent. You have to give them alternatives of this procedure. You will have to give them the benefits of doing this procedure and even the possible failure of this procedure. So they have to sign consent. After that, you can start doing access cavity preparation. In B, after you do access cavity preparation, you're going to take working lengths. Now, those of us who have apex locator, the apex locator might not work in this case because the apex is blunderbuss, it's flat, it's open, it's a highway. So the apex locator measures the area of the frequency between the apical constriction and the great diameter. In this area, in this radiograph, the apex is highway, no apical constriction where your apex locator is going to work. Therefore, you insert a small file around 1 millimeter short of the apex of the tooth, and then you do a working length radiograph. After you do that, you start biomechanical preparation. I must emphasize that it should be minimal. If you do aggressive, you are going to destroy the potential stem cells we talked about, the potential growth factors that are fossilized on the dentine wall. On this young permanent tooth on the wall, we have potential fossilized stem cells and growth factors. If you're going to do excessive biomechanical preparation, you are going to destroy them. And therefore, the outcome of your regenerative endodontic procedure is going to be lower. After that, you irrigate. Have a look at C. In C, there is a 1.5 sodium hypochlorite concentration. Let's pause here. So which concentration, people will ask, is the sodium hypochlorite? 1.5% up to 2.5. Do not go higher, although some people are still doing, in normal root canal treatment, we use a concentration of around 5.26%. In these cases, because we don't want to destroy the stem cells and the growth factor, so you use a lower concentration. Because you're using a lower concentration of sodium hypochlorite of 1.5%, therefore, you are supposed to use copiously. If you're using a 5 millimeter CC needle, you need 20 milliliters, 20 injections of sodium hypochlorite into this pulp chamber. Remember, we have done minimal cleaning. Therefore, we are going to maximize on the low concentration of sodium hypochlorite, a concentration of 1.5 milliliters up to 20 milliliters. So 20 divided by 5 is 4 times. You load your needle in a syringe, disposable hypodermic syringe, 4 times. You are going to disinfect this tooth because we have done minimal preparation. That's very important. And then after that, the canals are dried. Once you've done minimal cleaning and then irrigating with 20 milliliters of 1.5% or 4 hypodermic needle syringes, you are going to dry the tooth with pepper point. Of course, how do you remove sodium hypochlorite? You've irrigated 1.5. You are going to use normal saline with the same amount, 20 milliliters, so 4 injections, irrigations, not injections. And be careful, you must use a side vented needle. Otherwise, you are going to cause a hypochlorite accident, you are going to inject hypochlorite in the tissues periapically. And apart from causing hypochlorite accident, all the stem cells will undergo apoptosis. They will undergo death, not apoptosis, but they will die. They will become toxic. Therefore, you have to use a side vented needle, and then your needle should be at least 2 millimeters away from the open apex. After you're done with your irrigation, you remove sodium hypochlorite with normal saline, the same amount of 20 milliliters. And then you use a sterile paper point. Don't just pick your paper points from those little boxes and put there. They must be sterile. Anything we get out of those small boxes are not sterile, including our carapacha. So how are you going to sterilize your paper points? You can use glass beads. Glass beads are the ones used to sterilize the paper points. Because you are doing a regenerative endodontic procedure, you don't want to cause any slight mishap. Otherwise, your procedure will just fail. It is going to fail. I must also emphasize, apart from sterile paper points, you must have to use rubber dam. I'm so happy because in Nairobi, I've not been to Zimbabwe, Uganda, or Tanzania. I've been to Dar es Salaam, Muhimbili University, and I've also been here in Nairobi in my colleagues in pediatric dentistry, the specialists in the Kenya Association of Pediatric Dentists. It's amazing. Every clinic I have been going the past 2 months, even you don't ask, but they always do rubber dam. I must commend them, because if you're doing such procedures without rubber dam, for sure, you're going to fail. So you better refer to a specialist, for example, a pediatric dentist, to do this procedure, because it's really effective. You're going to minimize any infection. So after you've dried, so this is appointment number 1. A, B, C, D is appointment number 1. After you dry the tooth with the paper points that are sterile, so you are going to dress the tooth with what? The triple antibiotic paste, if it's your choice. There are disadvantages, advantages. The double antibiotic paste, or the single antibiotic paste, augmenting, or non-setting calcium hydroxide. So you have 4 choices to make. At this stage, you are going to dress this tooth for 3 to 4 weeks. 3 to 4 weeks with your antibiotic of choice. And then you put a temporary restoration, for example, cavity or interim, a thickness of at least 4 millimeters. So you are going to use a thickness of 4 millimeters of temporary restoration. Anything less than 4 millimeters is going to cause micro leakage. Therefore, your temporary restoration is going to be at least 4 millimeters thick. And then you recall the patient after 3 to 4 weeks. And then on the recall appointment after 3 to 4 weeks, as you can see in photo number E, intracanal. So when the patient comes back after 3 to 4 weeks, where do you begin? Examination. You ask them, how have you been? Any signs of pain or discomfort or swelling? You do percussion tests. You do all those tests. Inspection, palpation, percussion, and then take radiograph. At this moment, you have 2 options to make. If the tooth is symptomatic, you repeat steps A, B, C, D. If you really want to do regenerative, or you drop it at this level. But if you have a chance and there is symptoms after 3 to 4 weeks, repeat A, B, C, D. If the symptoms have gone, then proceed to E. So the picture you're seeing in E is after 3 to 4 weeks of recall. And then you ask the patient, has it been symptomatic? Have you undergone any swelling, any pain, or any inflammation? Are you able to eat with that tooth? If the tooth is asymptomatic, then you are going to remove the medicaments you used. We used which medicaments? Either triple antibiotic paste, double antibiotic paste, or the single antibiotic paste. Or if you use calcium hydroxide, so you remove it. I must emphasize this also. In the first appointment, A, B, C, D, you inject the patient, you anesthetize the patient with a local anesthetic with epinephrine. That's okay. However, in stage E, the second appointment, where we want to start the regenerative endodontic procedure, do not inject the patient with a local anesthetic containing a vasoconstrictor, for example, epinephrine. You can use 3% mepivacaine. 3% mepivacaine has no vasoconstrictor. Therefore, it's recommended in regenerative endodontics on the second appointment. After you inject, anesthetize the patient with 3% mepivacaine, then you remove the intracanal medicaments by irrigating with what? 17% EDTA solution is effective to remove calcium hydroxide. People have also, at this moment, usually we don't recommend a high concentration of what? Sodium hypochlorite. So you simply use 17%. If you have to use sodium hypochlorite, maybe 1% concentration, not even 1.5, because at this moment, healing has started. The stem cells are now being activated by the calcium hydroxide, so we don't want to disturb. So 17% EDTA solution, in fact, it will fossilize the fossilized stem cells into the dentine. And then you rinse the canal with normal saline to remove the EDTA. After you rinse the canal with EDTA solution, so I repeat again, second appointment, anesthetize with a local anesthetic that does not have a vasoconstrictor, for example, 3% mepivacaine. After you anesthetize it, the next thing is you remove your intracanal medicaments using a lower concentration of hypochlorite, followed by 17% EDTA solution. Because these two react, so you have to put some normal saline in between when you're moving from hypochlorite to 17% EDTA solution. And then after you remove this, now, this is the interesting bit. We want to form a blood clot. We want to form a blood clot inside this pulp chamber. How do we do that? The recommended is a hand file. Hand file size 25. Hand file size 25, you pre-curve the apical 2 millimeters. So size 5 hand file, you pre-curve the apical 2 millimeters and then extrude it. You extrude it 1 to 2 millimeters beyond the apex. Size 25 hand file, pre-curved from the apex, extruded 1 to 2 millimeters beyond your working length, and then you rotate it. So you rotate this pre-curved file at the apex. Your intention is to lacerate. Laceration. You're going to lacerate the apical tissue to induce bleeding. You can see in E, now they have lacerated the apical tissues and now there is bleeding inside the canal. This blood is coming with what? A high delicate of stem cells and growth factors, and it's going to form what? A blood clot. A blood clot is important in what? Tissue engineering, as we said, that the three triad, the blood clot, the scaffold, and the growth factors. At this moment, we are introducing the first one. Actually, the second one, because EDTA already released our growth factors. So the second laceration is bringing in the scaffold, the blood clot. After you have released the blood clot, it is coming up the pulp up towards the cervical area. So what do you do? If you put a membrane, so this scaffold, the one we say the collar plug, like for example, this collar plug is just collagen. This is a collagen membrane that has been put on top of the blood clot. You went inside the canal with a number 25 file. It must be sterile. Otherwise, there'll be a secondary infection. Number 25 file, pre-curved at the tip, extended 1 to 2 millimeters beyond the apex. You lacerate the apical tissues. They bleed, causing a blood clot up into the open pulp chamber. You cover this blood clot with a collagen membrane. For example, this is just a trade name, collar plug, as you can see in picture A. So you cover it and you push this collar plug 2 millimeters below the CEJ. Push it 2 millimeters below the cemento enamel junction. Why? To reduce chances of what? Staining. So, just think, just a minute, I think I missed this one. Let me, I think we are back now. So in F, if you can see, in F, we have collar plug, and then you push it 3 millimeters below the CEJ. So you can see the blood has stopped bleeding. The pulp chamber is now have undergone hemostasis. So we have a blood clot. On top of the blood clot is the membrane. This membrane is 3 millimeters below CEJ. So this 3 millimeters below the CEJ, we fill it with what? We fill it with MTA. Now, very important, what are you going to use to put on top of this collagen membrane? Is it MTA? Is it biodentine? The gray MTA has been shown to cause staining after regenerative endodontic procedures. Therefore, you can use white MTA. Although white MTA also causes slight staining, but it's better than the gray MTA. If you want to avoid MTAs, biodentine has superior outcome. Biodentine has been shown by research to cause minimal, even no staining. In my opinion, I'll choose biodentine, or if I don't have access to biodentine, I'm going to use white MTA. Now this white MTA is going to replace the 2 millimeters below the CEJ. So it's a 3 millimeter rule, 3 millimeter rule. 3 millimeters of collagen below CEJ, 3 millimeter thickness of MTA or white or biodentine. And then after that, what do? You cover on top of the MTA, you are going to put your GIC as a seal. So this one will prevent any increase of microbes from coronal aspect. So GIC, you can use Fuji 9, even Fuji 7. They have very good sealing ability. So we have many things in the pulp chamber. The blood clot came all the way. On top of the blood clot, we put a membrane. On top of the membrane, we put biodentine or MTA. On top of MTA, we have what? The GIC. So what next? How do you cover the GIC? You do your normal restoration, composite restoration. So you do composite restoration, and then after that, you take a post-op radiograph. So you'll be able to see something white. So the white radio-opaque appearance of this tooth is the composite restoration coronally, followed immediately underneath by GIC and then MTA. You can appreciate that the MTA is just 3 millimeters below. And the radiolucency in the pulp chamber, in the canal space, is the blood clot with a high delegation of what? Growth factors, cytokines, and then what else? Immune cells. They are going now to build this completely previously destroyed necrotic pulp chamber to make it live again. And then after that, you do recall. Okay, so recall usually shows that there is continued tooth development, and then there is also thickness, increased thickness of the dentine wall. How do you know that you have done your regeneration? You do electric pulp testing. You follow up the patient 3 months, 6 months, 12 months, up to 4 years. 4 years before you say, this is a successful procedure. In those visits, you are going to take history, radiographs, examination, and the most important thing, reliable test, is the electric pulp test. So if you do not have an electric pulp test, it's very hard to examine the outcome. The pulp vitality test, for example, the cold test and the heat test, will show minimal results. Why? Look at picture K. If you can look at picture K, we have a radiopaque substance from the coronal aspect of the tooth all the way to 3 millimeters below CEJ. Your cold test will not reach there. Your heat test will not reach there. Your pulp vitality tests are not helpful at this moment. Therefore, you rely on what? Electrical pulp testing. Therefore, you can buy an electrical pulp tester to help you. This is the last case. We are done, by the way. So that was the first case, and this is the last case. In this case, they did not use a blood clot. The first case, what did they do? They used a 25 file, pre-bent from the apex, extruded, and then lacerated. In this case, they did not use a blood clot, but they used what? Platelet-rich plasma. So they had to do a vein puncture on the patient. They drew blood. So they drew blood from the patient, and they went to make the what? PRP. Once they made it, they came and followed the protocols. In figure A is the pre-op radiograph. Picture B with a dark pulp chamber is this PRP. The platelet-rich plasma has been injected. So they just inject directly instead of causing trauma to the apical tissues. By lacerating with the file, you now inject the platelet-rich plasma directly inside. Kindly inject 3 millimeters below the CEJ to avoid discoloration later. Once you have the platelet-rich plasma inside, and then you are going to do what? You are going to cover it with collagen membrane, same stage. On top of collagen membrane, you cover with biodentine or MTA. On top of MTA, you're going to do GIC. On top of GIC, you're going to use what? A restorative composite of your choice. And then usually the outcome is good. So I repeat again, during the second visit, you should examine the patient and see whether there are any symptoms or not. Okay, so A is preparative radiograph. The one below A is on the bottom left, access opening, minimal instrumentation, and then top right picture, working length determination, and then final radiograph. This case was followed 36 months, that's 3 years, and you can see there is resolution of symptoms, and then the apex has closed already. So we have regenerated the pulp. But wait, it's not yet over. Have you regenerated it or not? How do you confirm? What are the treatment outcomes? Number 1, no symptoms, resolution of infection at the periapical area, and then your tooth should respond to your EPT. EPT is electric pulp testing. Otherwise, you wouldn't have done any regeneration yet. There is no living tissue. And this tissue, for it to be responsive to electric pulp testing, so it must have at least what? Nerves. And then nerves cannot survive with what? Without blood supply. So they have a mixture of blood supply. That's why my mentor, Dr. Dienya, had to change the topic to filling the nerves, the canal with nerves and blood vessels. And actually, apart from nerves and blood vessels, you will find what? Dentin-like, cementum-like, and bone-like hard deposits inside the root canal space. So in conclusion, this is just a repetition. How do you know the outcomes? There are three. How do you know that you are successful? The primal call, which is essential, elimination of symptoms. Number two call is to do what? Increased wall thickness and root length. And the last treatment outcome to know that you're successful is to do what? Positive vitality test. And which test do you do? Electric pulp test. Then you are all so happy that you've saved the tooth. In conclusion, I can say, as you can see in this picture, we still go back to our triad. You can see in the picture, we need what? Stem cells. What else do we need? Scaffolds. The blood clot is the natural scaffold that God has given us to use. Growth factors. How do you get the growth factors? You treat the wall with what? Bioactive materials like 17% EDTA solution, also calcium hydroxide, to release the fossilized growth factors. And then the next research now, which I'll challenge everybody, both Kenya and Zimbabwe, to try this procedure in a fully formed permanent tooth. This is what people are struggling with. Actually, my professor in the Philippines, Dr. Luigi, he just came from Japan, and they used fish collagen. You know the tilapia we eat? I love tilapia, but recently I realized the fish collagen can be used to regenerate. So it's the scaffold. So our professor in the Philippines had to discover this. Fish collagen can be used as a scaffold apart from the collagen. So we were happy for him when he came back and he told us that story. So we are working alongside to see what else can we discover in that line as a scaffold. So this is the tissue engineering, the current research people are doing. And in Canada, they are now into nanoparticles. Nanoparticles. There's a professor in Toronto, Canada, who is doing nanoparticles as scaffolds. Maybe next time, when I'm given time, I'll share the nanoparticles in regenerative endodontics and really helpful in regeneration. Otherwise, our hope is just tissue engineering now, okay? Regenerate the pulp dentin complex. Otherwise, thank you so much. This is Dhanyavad in Nepal. We used to have Nepalese classmates. Dr. Subu is, I think, live also watching this presentation from Nepal. This is how you say thank you in Nepal. And in India, we say Dhanyavad. And then in the Philippines, we say Maraming Salamat Po. And then in Kenya, Asante Sana. And then those who are colonized by British like me, thank you so much. Otherwise, God bless you. Back to you, Dr. Ere, Dr. Nick.
Thank you, Dr. Simiyu. That was very, very, that was excellent. In fact, I'm wondering whether it's too late for me to become an endodontist.
Not too late.
Never too late. Huh?
Yes, not too late.
Okay, so we'll go straight into the question and answer section.
Yes.
We have very many questions for you, which actually is a representation that this was perfect. So one of the questions we are asking is, when you mentioned augmentin being a single paste, are you injecting IV augmentin into the pulp chamber? Are you grinding the tablets into a paste, or do we have a commercial preparation for dental augmentin? And what's the dosage that you use per canal?
Well, you crush the tablet. And as I showed in the picture, because these are young people, so 457 grams. So actually, the triple antibiotic paste should not be used more than 1 milligram per ml. So same principle. When you crush your augmentin, you don't put the whole tablet of 457.
Mm-hmm.
You can use up to 1 milligram per milliliter. So you crush it and mix it with normal saline. Yes.
Injected. And how available is the triple antibiotic paste or the double antibiotic paste in Nairobi, in Kenya?
I do not have any store in Kenya in mind who was doing this triple antibiotic paste. Initially, it originated in Japan, and I'll just find out which store in Japan has got this triple antibiotic paste. But Dr. Nick, this triple antibiotic paste is no longer approved by the US Food Administration. So the US are not using this anymore. So I don't know if Kenya Dental Association or pharmaceutical companies. Why? Because of the issue of what? Adverse effects, the allergic reactions, the what? Resistant to antibiotics later. And we don't know this component. No research has found the interactions between minocycline, metronidazole, those three, they react at a certain level. We do not know what's happening. And another thing, it's hard to remove them from the canal. So the US hasn't approved yet the TAP. TAP is for triple antibiotic paste. And I do not know a store yet in Kenya.
But you can still get the individual drugs and paste, grind them and create a little paste out of them.
Yes, and you must not make sure that what? It should not, the concentration should not be more than 1 milligram per ml.
Okay. And when you mentioned that to irrigate the sodium hypochlorite is 1.5, any advice on how one can make that concentration? How does one dilute the sodium hypochlorite?
I think any pharmaceutical company can do that, even the crushing of those triple antibiotic paste, so that you come up with what? A 1 milligram. And also the same with the hypochlorite concentration. I do not know if there's, because we are not doing these procedures routinely, so there's no store that supplies 1.5 milliliter. So that one we can ask the pharmaceutical companies or our friends in pharmacy. This is conch hypochlorite. Can you make it 1.5 ml?
So with this regenerative endodontic procedures, and this being a relatively new procedure, is there any drawback, and is the root development that one achieves, is it as ideal as normal root development?
Well, on the drawback, yes. If you do not follow proper protocol, for sure, you will fail. And then what was the other question apart from drawbacks? So drawbacks could be failure or retreatment. In that case, you go back to our traditional apicification or apixogenesis. So yes, there are drawbacks. That's why you need to sign a patient consent, including the parent, and alternatives for this procedure. There was a second part of that question. What was it, apart from drawbacks?
The second question was, if, for example, you have done the procedure and it's very successful, yes, is the root development equivalent to the normal physiological root development?
Not really. And research has shown that inside that newly regenerated tissue, it's not an ideal dentin pulp complex. It's a mixture of cementum-like tissue, bone-like tissue deposited inside with loose connective tissues from the periapical, from the PDL. So it's not like the ideal original. You know, the original was formed by the primary cells. These are cells coming and homing, migrating, being recruited from elsewhere. They will not form, actually when under histology, they are loose connective tissues. And even the dentin that is formed, the dentin-like structure formed is a fibrillar without fibrils and even lacks dentinal tubules. An odontoblast once killed cannot be even formed. So the one you've regenerated is not as original as the former.
I think that is clear. I think, could you kindly go into the clinical indications for regenerative endodontic procedure over other procedures like apexogenesis and pulp capping?
Sorry, Doc?
What are the clinical indications for regenerative endodontic procedures over procedures such as apexogenesis and pulp capping?
Well, it depends on your case. Is it a young permanent tooth? Is the root almost like Prof. Sivek, the Sivek pulpotomy? You remember Prof. Sivek, classified stages of development, 1, 2, 3, up to 4, 5. 4 to 5, it's indicated for apexification. You just do normal root canal and seal with what? An MTA plug. However, stage development 1 to 3 is indicated for regenerative endodontics. Both procedures are successful. It's not a treatment failure. Because we are faced with different situations, I want to do regeneration. I do not have TAP, the triple antibiotic paste. I do not know how to mix augmentin. I do not know how to mix 1.5% hypochlorite. So I am going to do what? Apexification. I am going to do what? Apexogenesis. So both of them have got an outcome. Our aim is to do what? To retain this tooth in a functional status in the mouth. Should the patient need an implant later? Well, there is already bone around it, unlike extracting this immature tooth. So the indications depend on the age and the stage of development, if I can say that. Yeah.
So the classification is the best thing to use. You don't need to categorize if a tooth is vital or non-vital.
Oh, thank you, Dr. Gishu. Now, in the next lecture, we are going to do, I think, on 13th with the KDA, there is a paradigm shift in classification. Diagnosis in endodontics has changed. It is no longer irreversible pulpitis. It is no longer reversible pulpitis. There is much more. So you have to classify the diagnosis. So that one, I will just summarize by saying there is currently pulpodiagnosis. There is apical diagnosis, which we are going to meet on that 13th. The KDA is organizing a seminar on that and the biotics used. And for your pre-op radiographs, I can see Dr. Nanji is asking if there is trauma, a CBCT is important because you might go in trauma case, yet the root is fractured perpendicularly or horizontally, and your normal periapical radiographs might not detect. So I strongly recommend a CBCT, especially on your evaluation, the tooth was as a result of trauma. So CBCT can help also to assess, is there any fractures of the alveolar? Yeah.
Is it possible to use sterile water for injection instead of saline to irrigate?
Because we are dealing with cells in the human body, I would, unless I want to fail from the first go, I would rather fail to mix 1.5% than fail to produce normal saline. It's not expensive. It has been normalized, and the concentration, the pH and every other factor is equivalent to our normal cells. So kindly just buy normal saline if you really want to have a high successful outcome.
Okay, there's a question asking, how do you sterilize pepper point and gutta pacha?
Oh, I already said paper points are sterilized using glass beads. Just Google glass beads.
Glass bead.
And then cadapacha are not sterilized, but they are disinfected. How do you disinfect it? Before you do obturation, please, you will have perfect biomechanical preparation. You'll have perfect obturation, and the patient will come with pain and swelling. When you take radiograph, everything is perfect. But the cadapacha you got out of that packet, it's not sterile. How do you disinfect it? You take your master con, so please take your master con, dip it in conch hypochlorite, 5.25% concentration for 1 minute, not more. Actually, at the University of Nairobi, my next research class for 4th years, we are going to do an experiment. What happens when you put cadapacha in hypochlorite for 1 minute, for 2 minutes, for 3 minutes? The recommended protocol is 1 minute of soaking your cadapacha, the master con, and all other accessories in hypochlorite for 1 minute. How do you remove the hypochlorite from the soaked cadapacha? You are going to take it out and then swab it with alcohol, not Tusker, but the spirit swab, 70% alcohol. So that's how you do pepper points and cadapacha.
For the antibiotic paste, are they suitable for intracanal medicament in routine root canal treatment?
No, because of the side effects like hypersensitivity reactions, allergic reactions, and later on when the patient gets sick, they might become resistant. This is a current trend that's going on. People are no longer healing because of what? They were exposed for a certain number of days on an antibiotic. So I do not recommend that. What I recommend is research shows, not even me recommending, because personal opinions are not held with high regard. But I'll say research recommends non-setting calcium hydroxide. It's also an antibiotic. So yes, it's an antibiotic.
And when you've dressed the canal with the calcium hydroxide, like you said for the second visit, how do you successfully remove the calcium hydroxide? What irrigant should one use?
Research shows 17% of EDTA solution easily removes calcium hydroxide from the walls, unlike removing the triple antibiotic paste or the double antibiotic paste. Those were hard to remove, but 17% EDTA solution will remove your calcium hydroxide. Then you follow, actually they say 20 milliliters. So again, 5 irrigations with your 5 millimeter needle, hypodermic needles, followed by normal saline. On the second appointment, please do not use a high concentration of what? Hypochlorite, because at that moment, healing has begun. And therefore, you are going to destroy the stem cells that are already mobilized. Yeah.
Okay. So once you irrigate with EDTA, you follow up with a normal cell line irrigation again. Does it rinse out the growth factors released by EDTA?
No. The normal saline just removes the solution of EDTA, dilutes it and removes it from the canal. It has no aggressive effects of pushing out or flushing out these cells. Also, these cells are not just hanging on the walls, okay? They are not hanging in the pulp chamber so that you just flush them out. So it cannot.
Okay. So what happens if while inducing the bleeding,
Yes.
you are unable to have a clot formation, or you just have continuous bleeding?
Number one, inability to form a clot means either you used local anesthesia on the second appointment with a vasoconstrictor, like epinephrine. That's when you will not have a blood clot. So use 3% mepivacaine. If there is continuous bleeding, wow. So maybe I'll say you don't aggressively lacerate on the first appointment, on the first turn of your 25 size file. You do it slowly first. Maybe the patient also has a history of blood problems. That's why examination is important. Does your family have history of blood clotting issues? So you have to ask that. If there is prolonged bleeding, you just wait until the blood clots and you remove the excess until you are 3 millimeters. The 3 millimeter rule, remember, 3 millimeters below the CEJ. And then in this case, there will be chances of staining of the crown later. So you have to use something to remove the excess blood on top, and then remove as much as you can after the blood clots until 3 millimeters below CEJ. Yeah.
And how do you ensure that the clot is 3 millimeters below the CEJ?
You just, usually the normal prosthodontics will correct me on this, but the normal crown length, the average crown length is around 7 millimeters. Correct me if I'm wrong. So I'll put my file 7 plus 3, so 10 millimeters. Yes, that's what I'll do. Then I'll know I'm just 3 millimeters below the CEJ because the crown height is 7. I need another 3 to go 3 millimeters below.
What are the success rates of this procedure?
91%.
91%. Okay. And likely costing, for example, in private practice, is it the same like a root canal treatment or?
Yeah, maybe slightly more than root canal treatment because you are going to use expensive materials like biodentin. I don't know how much it's costing in Nairobi or in Zimbabwe. I don't know how much it's going, but this procedure can be more costly than a routine root canal treatment because of the biomaterials you are using inside.
Just to clarify again, you said that during the biomechanical preparations, you try and leave out the walls, right? You try to do less minimal, yeah?
Yes, minimal preparation.
Okay. So in such cases, like in the Schweck classification, I think what classification A and B and C, where you have the root has not completely formed, do you have the same problem with dentin in the coronal portion, or it's just a root problem? Is the crown fully formed? Is the dentin also? Do you expect more growth in dentin in the coronal aspect?
No. Actually, now the researchers are now trying also to increase the thickness in the coronal aspect. Mm-hmm. In the coronal aspect, it's not there'll be no thickening because you have biomaterials there, the 3 millimeters. So actually, I read a paper yesterday, and they were saying now scientists are now being urged also to increase the thickness in this region. What I explained to you today has been done since 2002, and they're just trying to increase from 3 millimeters down all the way. But below coronal, there is none. So this area is also weaker. That's why you need to do minimal cleaning and shaping. So it's not so thick, and it cannot be increased because it has a biomaterial like MTA on it.
And is chlorhexidine an option for disinfection or irrigation?
According to researchers who have done this, like Prof. Borgen in the University of Pennsylvania, he has tried different irrigants. At the end, they concluded and said, sodium hypochlorite, it's the number 1 on your list. Citric acid can do, but it's not, it has a lesser efficacy compared to sodium hypochlorite.
And what happens when you've done all this and you have failure? What are the options that you're left with?
Then you do conventional endodontic treatment, and this time you do apicification.
preferably with MTA.
Yes, preferably with MTA or biodentine, which does not stain. MTA also doesn't stain if you're using the white MTA. So resort to the back to the conventional root canal treatment.
Even when you have the thin walls in the root.
Yes.
Okay. Another question was, can this procedure be done for a tooth that was avulsed and reimplanted immediately and radiographically is within stage 1, 2, and 3?
Oh yes, any tooth less than 60 minutes out of the mouth can be done this procedure. Why? Why not? Yes, it can. And there's a protocol for that. Trauma, when you go to the Journal of Traumatology and Pediatric Dentistry, there is a different protocol for handling avulsed teeth. So long as it's less than 60 minutes out of the mouth, yes, you can attempt.
So in the event that a successfully regenerated tooth ends up getting irreversible pulpitis in the future, how do you go about it? And what are the chances of getting sclerosis in the canal?
If it fades later, just like I answered before, go back to the principles of conventional endodontic treatment. And avulsion, unless there is a history of trauma, yes, it can happen. But if no history of trauma, it might not happen. You just do apexification. And there are principles to be followed when you're doing apexification.
So what is the commonest complication in regenerative endodontics?
Maybe I've seen cases of sinus tract forming, meaning there was no healing. And then pain and swelling, those are the most common. Just switch on to the conventional endodontic treatment. Yeah. So pain, discomfort, yeah.
Are there any cases of internal or external root resorption?
None that have been reported, because we have cleaned and disinfected the pulp chamber and then extracted the fossilized growth factors. So there are no polymorphonuclear cells or giant cells, clastic cells to cause resorption in these cases. In any way, they are just young permanent teeth. So they have many pluripotent cells, which are much more than the clastic cells. I haven't come across cases where they did this and then encountered internal or external root resorption, unless I'll search, but so far I haven't.
There's a comment here that there are some articles that say calcium hydroxide should not be used during regenerative endodontics because it is toxic to stem cells. What is your take on this?
The level of toxicity is lesser than triple antibiotic paste, lesser than the double antibiotic paste. That's why it now remains the best, and it doesn't have allergic reactions.
You mentioned that we should appreciate that the pulp is an organ. So does this have medical legal repercussions, especially in compensation or classifying the degree of trauma or injury? And should it be classified as such when filling P3 forms, for example?
Oh, I am not in the legal office, medical legal office, but so you didn't do any wrong to the pulp chamber. You didn't cause trauma, you didn't cause caries. So I don't think it has any medical legal implications, unless you didn't tell the patient the consent and you just tell them, oh, this procedure is highly successful. And then you go in and then it fails. So consent is important. Otherwise, yes, this organ will lead you to a legal office, definitely, if you don't do signing of consent.
Of consent. I think maybe, for example, in terms of a fight that ends up with a fracture, let's say, of an anterior tooth,
A what?
should be, if you had a fight, interpersonal violence, for example.
Oh, yes, yes, yes.
You have a fracture of a tooth with pulpal involvement. Should this maybe be classified as a, like serious trauma, since we're dealing with an organ as opposed to just a tooth?
Okay, I really make the tooth sound so big organ like the heart, the pancreas, but forgive them, for they do not know what they were doing, maybe. And anyway, we have what? The doctor's indemnity covers. Or the person who injured that person.
Yeah.
It's not, yeah, but if someone wants to sue the person, well, but let the dentist not write a big report. You know, this case was presented in my office, and then they had destroyed an organ. You see.
Yeah. a vital organ.
A vital organ, yeah. So that the person can get a lot of money. So let's not really make it so bigger. Just be good to your neighbors.
Okay. There was a question about PRP. Have you used PRP in an adult, in a permanent tooth?
Oh, I actually wanted, permanent tooth?
Yeah,
not yet. As I said, as I was concluding, that's where the research is. If anyone wants to do regeneration, the first person to regenerate the adult tooth, wow, I think they'll win our Nobel Prize. So far, no studies yet. No one, even myself, I haven't.
In cases of failure, again, I think there are many questions with regards to failure. How easy is it to remove the MTA or biodentin? Are there any special tips?
Because it's just 2 millimeters, 3 millimeters. So you can do with any dedicated drills. Yeah, any dedicated drills, even post drills, or any, even a small tapered burr, because it's actually centered. So you just need to create a small opening and go 10 millimeters from the incisal edge. So it's not so hard because it's not all the way to the apex. If it were all the way to the apex, for sure, there'll be challenges of perforation.
There's a question from Dr. Kubasu, who also echoes that she also feels that she might be too late to be an endodontist. We've had a lot of emphasis on regenerative endodontics with regards to anterior teeth. Do we get the same success rate for first molars, maybe even second molars with pulpal involvement for children?
I haven't come across cases documenting those teeth, so I may not comment on the success rate, because they of course are bearing a lot of forces of mastication. So I will have just to do my research again and not give a personal opinion on that. Then maybe I'll respond in the next lecture. But I haven't come across case reports handling the second molars.
But is it something that you'd advise one to attempt for if it's the first molar?
Oh yes, doc, why not? So long as you're able to extirpate all canals and locate them, why not? You can. You can do that. Maybe I recommend, because of healing, you put this tooth slightly under occlusion, below the occlusion, so that it's not constantly having occlusal forces on it. So yes, but remove the stress by making it underfilled until you are ready for the final maybe crown after 18 years.
Another question is, once you've done the dressing, whether it's the single paste, triple antibiotic paste, or the calcium hydroxide paste, should we still cover the patient with oral antibiotics like augmentin and metronidazole? Is there a role for systemic antibiotics?
There is no role. All these cases reports, they never prescribe the patient any. In our lecture on 13th of August, we are going to do the paradigm shift in antibiotic pharmacological prescription in endodontics. Things have changed. You just don't prescribe. Why are you prescribing? The only case where you prescribe is when we have acute apical abscess. Only acute apical abscess. If there is a discharging sinus, I do not personally medicate. If there is pus, I can see it drooling with an opening on the sinus, I do not medicate. It's going away, so I just need to remove the source of infection by doing proper cleaning and disinfection inside the root canal, and then put calcium hydroxide, and then the patient for sure will heal. That one will be more discussed on 13th of August.
An interesting question. Can the same treatment be done on a deciduous tooth if the patient has no permanent tooth, no succedaneous tooth?
Wow. What do you think, Dr. Nick? Now back to you, because you know I also want to be a pediatric dentist because we are really close, you guys. And actually, I'm joining your organization because we are going to do these cases together.
Yeah. But I think that was also, by the time you catch a deciduous tooth with an incomplete root formation, that would be a very, very young child. So
yes.
that would be a bit complicated.
Yes.
But I think
so
they're probably referring to maybe a fully formed deciduous tooth, where you probably still think of a pancrectomy as opposed to regenerative endodontics.
Yes.
Okay.
So I think you've answered it well, Doc. Yeah.
Can one harvest stem cells from a potentially impacted wisdom tooth? A wisdom teeth sources stem cells?
Oh yes, I showed you the picture. A picture of potential sources of what? Stem cells. Yes, wisdom tooth is a potential source, as you can see on the screen. There's a wisdom tooth there. Okay, so stem cells from the apical papilla. Why not? As you can see on the screen. Yes, it's a potential source. And now we have the banks, stem cell banks. You get out of your wisdom tooth, you harvest the stem cells, you put it in a bank, then use it somewhere. Yes.
So I think we'll just give you the last comment. This was from Dr. Wambugu. He says this has been very mind-blowing. He's impressed by the references to basic sciences, which we learn in the early years in dentistry, which confirms his thoughts that any innovation in dentistry shall come from a proper understanding of the basic sciences. And in this light, he's requesting if it's possible to have some form of webinar on some basic science lessons, and says a big thank you to you, Dr. Simiyu. Any comment?
Oh, thank you, Dr. Mbugu. Yeah, it's very joyful to hear a comment like that from our seniors. And yes, we can do a webinar on basic life, basic sciences in dentistry. And those who are interested in research, those are the principles we are going to use for future regeneration. So thank you so much, Doc. Yeah. And then Dr. Vitalis Ogola is saying, does this procedure conclusively address pain after the first appointment? As most patients come to us with pain as they're concerned. Of course, yes. So Dr. Ogola, the procedure will, yes, address the pain on the first appointment. Why? During cleaning and shaping, you are removing inflammatory mediators, the neuropeptides, all those cytokines, all those prostaglandins, you are removing them during your biomechanical preparation. So therefore, yes, this procedure will address the pain on the first appointment, Dr. Gola.
So thank you very much, Dr. Simiyu. That has been very informative. It's been an excellent lecture. We're looking forward to having more lectures with you and more interactions with Endodontic Skills Academy as you teach most of us, as you appreciate that we also have undergraduate students present in this webinar, and they've all shown a lot of interest with regards to this. We'd also like to thank Zimbabwe Dental Association, Dr. Soka and Dr. Vicky. Thank you for agreeing for us to collaborate and inviting the team of dentists from Zimbabwe as well. This has been a very good collaborative effort from both parties as we try and foster more relationships within the dental fraternity regionally and in Africa. We'd like to announce again that all CPD points for the Kenyans who registered correctly shall be fed automatically into the ICPD portal, hopefully by Saturday. We try our best to send them as soon as possible. Thank you again for attending. We appreciate your presence, and we'd like to tell you guys to have a very good evening. And thank you, Dr. Simiyu, once again. We hope to have you soon.
Thank you, Dr. Gishu.
All right.
Okay,
So,
bye.
Perry,
Dr.
goodbye.
Thanks, bye.